Hi, everybody. It's Karen Anderson here with Aortic Hope for our next live Q&A event for Aortic Disease Awareness Month. So before I get started, please click that like button, click subscribe, and click the bell. This way you'll be notified every time we go live because we know our memories aren't that great. So let the computer do the work for you. Go ahead and click that. I am here with the very popular Dr. Ben Youdelman from Maimonides Medical Center.
Hello, everyone. It's so nice to be here in Hawaii, resting and relaxing for the day and the weekend, and then returning to Brooklyn after the show's over.
Yeah, I bet. I know you wish. That's all right. It's always good to wish for things. It's good to want things.
Being lied to by a heart surgeon is something that does happen from all of us from time to time.
Yeah. All right. With that said, we're doing something different this time. We usually start off with ascending, type A, type B, ascending, all of this stuff that you got me remembering, no contact sports outside of the bedroom, all that stuff that you've said in the past. But today's different because you mentioned to me that you're now taking on this extra work of the AFib Center, correct?
Yeah, so a little bit of a aside to what I do most of the day.
Yeah.
There is a surgical side to atrial fibrillation, or AFib, that our group has been doing, and I wound up doing it with my senior partner who retired, and so I took over the program a few years ago and have been doing that. And honestly, it didn't really occur to me that this was something that we should be talking about until we got onto a discussion of all the topics and subtopics for September. And then I mentioned it to you, and that's how we got here.
Yeah, and it's crazy because I think a lot of us are sitting kind of in silence, not realizing how many of us have some type of arrhythmia that probably showed itself or is showing itself more predominantly since aortic dissection or since surgery. So let's just focus right this second on AFib, and let's talk about what it is and how it may or may not impact people in this community. And we'll just get into everything AFib.
So if we go back, and this is going way back to a study that maybe you guys have heard called the Framingham study, which was done up and around Framingham, Boston, and it was a very broad study that encompassed a lot of patients, thousands and thousands of people. And it was found that patients who are in atrial fibrillation have a incidence of stroke that was significantly different than patients who were in heart failure, or patients who had coronary artery disease, or patients who just had high blood pressure. So if you took the groups, patients who had high blood pressure, risk of stroke was about 3%. Patients who have heart disease alone was like 2.5%. Patients with heart failure, we know their increase, and they were about just over 4%. But patients with atrial fibrillation, with or without any of those other problems, they were close to 5%. And this prompted a series of studies to look at why. Around the same time, the technology to advance ultrasound, or imaging the heart with sound waves, started to significantly increase. The original ultrasound of the heart was actually just what's called 2D, or biphasic, and all it could really show would be walls going up and down or back and forth. And let me tell you, the people that were doing that originally were incredible. But once we started to be able to see the images live with multiphasic, and you could actually see the heart squishing back and forth and all sorts of things, what was noticed was that patients who presented with a stroke who had atrial fibrillation, 90% of the time, those patients had clots in their left atrial appendage. And now I know you're going to ask me what that is. The problem is none of the models, if you think about it, I have a lot of analogies, but let's think about it. You have a room where you walk in, there's like a door, small hallway, and then a big square, simple square room. The appendage is like that entry little hallway, and the left atrium is the big square.
Okay.
If the blood is not being moved around a lot because the atrium is not contracting, because in atrial fibrillation it just sort of does this, then in that little anteroom area you can get blood that's really, really not moving at all. So much so that it just sits there. And if it sits there long enough, it just clots there.
Yeah. So it kind of pulls.
Yeah, it creates a ball. And
Mm-hmm.
once that happens, it doesn't adhere to the wall. But what can happen is that the heart going like this can start to squeeze, and then it shoots those little particles out that are now clots and not just blood. And that can block arteries by going into your brain. It can go anywhere else, actually, but the ones we are obviously worried about is the brain.
So that's why people are put on things like Eliquis.
Yes.
Blood thinner.
So the original drug, everybody remembers, called warfarin or Coumadin. Then we came out with a bunch of these other drugs, which were called novel anticoagulants. Eliquis, Xarelto. There are a bunch of them. I'm not going to even bother using all the trade names. There were 4 of them that originally came out, and they're used in various different rates. And I'm not going to I have no vested interest in any of them, so I'm not going to spend too much time on that. But the whole idea being that those drugs did not require that you checked your levels, because warfarin basically blocks vitamin K, which is in broccoli, spinach, kale, kohlrabi, all kinds of green leafy vegetables. So if you don't regulate your green leafy vegetables well, and you take the same amount of warfarin, you actually can wind up unanticoagulated, because you basically are taking a drug that's competing directly with food that you're eating. So the balance is really what keeps you in an anticoagulated state. So we tell people, don't sit down and have a bowl full of broccoli if you're on warfarin, things like this. But the new drugs have been much more helpful in simplifying anticoagulation.
Would somebody know they had AFib? Is it something that typically people feel that would prompt them to say, oh, what is this?
I would say it's probably about half the people. We don't really have a good number, as you can imagine, but a number of people who say they have palpitations, quote unquote, can be put on a Holter monitor, which is a monitoring device where it keeps an eye on your heartbeat. And then you hit a trigger when you have symptoms. Most of the time, those symptoms are not related to anything related to your heart. They can be little muscle spasms inside your chest. They could be chest wall muscles. They could be all kinds of other things in your neck, not related to an arrhythmia at all. And that was proven many, many years ago. So we put people on Holter monitors to see if their symptoms are related to their heart or not. Now, once you have symptoms, and people always worry about AFib, you get on a Holter monitor for 3 days. That doesn't necessarily mean you don't have AFib, because some people will go in and out of it for various reasons, the most common of which is unknown. But then there's thyroid disease, electrolyte abnormalities, inflammation in the chest, pneumonias. People who have heart surgery, about 30% of patients after any sort of heart or aortic surgery can go into AFib just from the fact that people are mucking around in your chest. So it's not necessarily anything that is easy to predict, but once it starts and you identify it, then of course, if you get palpitations, people worry. But as a rule, Karen, a lot of people who have palpitations, who have AFib, also experience palpitations at a time where they don't even know. So the simple answer to your question is, I have no idea. The more complicated answer to your question is sometimes it is and sometimes it's not. And then the other part of that is that for the people who do know when they go into AFib, even though they don't like it, they're actually very lucky, because those are the people for whom we can get them on anticoagulation before they present with AFib with a stroke.
Right. That makes a lot of sense. Now, AFib in and of itself, if you're on the anticoagulant, is that anything that people need to be concerned is going to be fatal, or is it just a nuisance? And then
way to be dramatic, Karen. I mean, can you just start talking about maybe they get hurt a little bit, or have to immediately?
No, it's black and white. It's like A or B. Listen, you know who's talking to you, so you know whose brain this is coming from, and you probably know why I'm asking these questions. It's not a secret that I ask questions that might have to do with me.
Let's go back through. Let's take the stress off your brain.
Thank you.
The atrial fibrillation is
Yeah.
thought about in terms of what's called the CHAD vasque score. Okay, the CHAD vasque score is a very stupid mnemonic. Now, it was good when it was CHAD, which was simple because it was just congestive heart failure, hypertension, age, and diabetes. So that was cool. So you could just say, oh, what's your CHAD score? So then they said, well, let's add an S for people who've had a stroke. So now it's CHAD's score. So then somebody said, well, what if they have vascular disease? And what if they're actually age 65 to 74, not over 75? And what if they're male or female? And, like, what do we do? Oh. So then it became the CHAD vasque score.
Yeah.
So then they said, well, wait a minute, we're not weighting this correctly. This is not right. So now it's called the CHAD2 vasque score. Karen, I've decided in my life, all I'm going to say is there are risk factors.
Yeah.
And that's it. Because it's getting silly. I'm starting to feel very silly. But anyway, be that as it may, it is an algorithm that we use to tell people when things can occur at a high risk and low risk. And I mean, I think you know this from aortic disease. We talk about this a lot. Classic aortic disease. Patient comes to my office. I just had office hours, so I'm really versed on this today. Patient comes to my office hour. I had 2 patients today whose aortas were between 4.5 and 5 centimeters, right? For most of us in aortic centers, our indication for surgery in the ascending aorta is 5 centimeters. Both of them had aneurysms in the ascending aorta, and both of them had parents who lived into their 80s and 90s. They had siblings who were alive and well, and grandparents who died in their 80s and 90s and with no known disease. Both of those families, I'd say they're at sort of what I call the standard risk. And I stopped saying high risk and higher risk because people like when I say standard risk. I operate on those patients at the standard time, meaning 5 centimeters. Of course, the high risk people, the same patients come in and they say, everybody's dead. They all died of aortic disease. It's a disaster. I call that the Karen Anderson special. Disaster. Everything's a disaster. No. Of course, there's very few people that I know that have that many relatives. The ones that scare me the most are people who have a parent, sibling, and a child, meaning that they definitely are a carrier. So I can't even say they have an aneurysm or not. They're a carrier, definitely, and they need surgery, right? So that's the high risk group. Same with CHAD vasque score, right? So if you have a patient who've got these numbers and they're increasing over time, then they have a risk. So what are those actual risks? And I actually have some images. Do you want me to share the screen or just tell you the number?
Sure. Share screen. We love that. It's always exciting.
Let's see how we do that. Let's, I'm going to more and I'm going to, nope, I'm in the wrong spot.
No, there's a share button.
Looking for dots, share button. Where's the share? Oh, share button. Here we are. Screen. Let's see what happens. It doesn't want me to do that. Oh, here we go. Sorry. How's that? You see?
Here it comes. Yeah, look at that.
Okay. So in this scenario, let me see if I can make this a little bigger. I know I'd love to do like this to be a little bit better, but that's okay. I'm just doing it this way because so I can see you on this screen and me on that screen. You see, the idea is that if you look at these 2 groups, right, these are the patients with atrial fibrillation and without atrial fibrillation. And you look at the patients who have these CHAD vasque scores. So just look at it in terms of numbers, right? A higher number. Actually, let's flip back. So here's the CHAD vasque score. And the higher the numbers, the increased risk of stroke, right? So these are, you get 1 point for all these things. Congestive heart failure, hypertension, over 75, diabetes, stroke, or TIA. So if you go to here and you look at the patients over in this group who are not anticoagulated, right? So these are patients who have no atrial fibrillation, who have a CHAD vasque score of up to 5, they have a less than 2% risk of having a stroke. If you go down to these patients who have atrial fibrillation, you see the events rate, right? These are patients who are anticoagulated. We're taking two groups. So if you have patients without anticoagulation who are in atrial fibrillation with a maximum daily atrial fibrillation duration, okay, rarely 6 hours or pretty common. If you have it at all the time, then you have a 1.77 risk of having a stroke here, versus if you're anticoagulated, it's about half of that, roughly half of that. So the anticoagulation does help you, but it's not a panacea. It doesn't solve all your problems, okay?
Yeah.
And if you have atrial fibrillation that happens all the time, so persistent atrial fibrillation, then the chances of survival is lower than if you have it on and off. Even though I just said, if you like this clot's forming and then it squeezes, they go out.
Yeah.
But the thing is that if you're in persistent atrial fibrillation, probably, and this is an unknown because you can't take all the patients and identify all these things, my guess is persistent atrial fibrillation probably has clots forming in multiple places, not just in the appendage, and therefore that's why they're at higher risk. Whereas if you're in paroxysmal, the biggest risk is when it forms in the appendage, but the rest of it, if you're in sinus rhythm or the normal rhythm squeezing, it's not really going to form there. If you have no left atrial appendage, then you have fewer clots, right? And there's been a bunch of different studies. This is the one that we all talk about, which is that if you have heart surgery, which I'm very familiar with because that's what I do, or if you have aortic surgery, just like I did yesterday, I did an aortic replacement and I put a clip on the left atrial appendage because of this study. If you occlude the left atrial appendage, the incidence of stroke is less than if you don't. Simple answer. It doesn't make it perfect. It doesn't make it zero, but it is less. So if you have the ability to make less strokes in fewer patients, then we do it, right? So that's the whole point. I don't want to get into too much complicated stuff here, so I'm going to stop right there. We can talk some more. We can go back to these issues, but there you are again. Hello, Karen. Questions about all that?
Well, can AFib or any other type of arrhythmia, can they in and of themselves cause an aneurysm to form?
No, not that I know of. I don't think that the electrical system of the heart has that kind of power. And really, we always break the heart down into, the three groups. You have, you've got your framing, you've got your plumbing, and you've got your electrical, basically when you build a house, which I know you're very familiar with as well.
Yes.
So if the structure of the heart itself, right, the valve, everything structure is relatively intact, that's one piece. If the plumbing is intact, right, the vessels, including the aorta, then that's the other piece. And then the electrical system is a really totally different piece that is very little to do with any of this, except to say that we have to be well aware of the role that atrial fibrillation can play in the post-operative heart rate and blood pressure issues, and also decisions that we make intraoperatively where we can do what's called an ablation procedure, which we'll talk about, and put a clip or sew closed the left atrial appendage so that the clots forming in that is no longer a possibility.
Okay, so let's talk about that. Other than starting off, which sounds like you start off with medication once you've identified that, there's also, from what I understand, I could be wrong, do anti-arrhythmic medications work on AFib? Will it help to ease those symptoms like it could if you have PVCs or PACs or SVTs, like a flecainide is one that I've heard of, or taking a beta blocker, maybe increasing a dose. These are just things that I've heard of just in my own personal life. Are there other medications that could help reduce the incidence of AFib, or is that kind of separate and special from the others?
So the simple answer is what we do is we control atrial fibrillation in two ways. The first thing we do is we control the rate.
Okay.
If atrial fibrillation starts and it's very, very fast, meaning that every time your atrium does one of these, it goes right through and it causes the ventricle to squeeze. The rates can be up in the 120, 130, 140 range. Now, that's not as fast as SVT, which is 220, but it is very fast compared to what you want to normally be. And what happens is that the combination of the atrium not squeezing and then the bottom part of the heart going so quickly, it's not filling. And so you've got a bad combination that actually can cause the blood pressure to get very, very, very low in this immediate moment. So the first thing we do is try to just slow it down. And the way we slow it down is with conduction. So you slow down the conduction between the atrial, the sinus node and the atrioventricular node, and you can slow down the ventricle itself in terms of its reaction. So those are with usually beta blockers first, and a drug that many people have heard by now, I'm sure, called amiodarone. And is mostly the first line. There are multiple other drugs, procainamide and flecainide and sotalol and on and on and on. And those drugs really land in the purview of cardiologists who specialize in the electrical system called electrophysiologists. These are people that when I started in surgery, I'd never even heard of. And then when I became familiar with them, one of my partners in cardiac surgery called them the wizards. They do some very interesting things, burning areas of the inside of the heart and giving you drugs that most people never heard of and never used, and combination of drugs and things like that. Fundamentally, what they're trying to do is to change the rate of the atrium, ideally chemically converting it into sinus rhythm, then slowing the conduction to the ventricle.
Okay. Okay. What happens if medication isn't working the way you want? What's the next step?
So there are areas of the heart. I have to go back to my my video. I'm sharing again. So the areas of the heart where the sinus node. This is a super complicated picture, but this is actually the back of the heart. And this is the superior vena cava, this is the inferior vena cava. And right in this area is the SA node, sinus node. And somewhere over in here on the inside of the heart, sort of more towards the front, is the atrioventricular node. And that goes down into the ventricle and gives rise to both of the electrical systems that trigger the ventricle. The pathway from the sinus node to the atrioventricular node is not very well known. But what is very well known is that if we give it one pathway, it will follow that pathway. And this was modified by a guy named Jim Cox at Barnes Jewish Hospital. And what he did was really radical. He took the heart and made a little cut and then sewed it back together. Now, everybody always asks, does he make all the cuts first and then sew it all back together? No, of course he doesn't do that. He makes a little cut, sews it back, then makes another cut, then sews behind himself. But the idea was to create a maze of scar tissue and only allow the electrical signal to go in one pathway from the sinus node to the atrioventricular node. And it worked extremely well. But I'm sure you can appreciate just from the picture alone, it's quite complex. And this did not take hold because of the bleeding risks and the other issues associated with it. But the benefit was well appreciated. Now, what I'm trying to show you here is that if you look at the heart itself, you have the left atrial appendage and the right atrial appendage. And if we, sorry, that's a very funny picture I'm going to show you about later. Trying to show you a good picture and I can't find it. This is actually not a bad picture. These are pictures of the atrium, but these are the pulmonary veins, and this is the left atrial appendage. And if you can burn, literally burn or freeze and cause a damage to this area in this box. So on the outside of the pulmonary veins, and then encompassing the left atrial appendage and the outside of the pulmonary veins, it has been shown that this area is rife with the cells of the heart that cause these abnormal rhythms to propagate. And we're not entirely certain why. In addition to this area, there's another small vessel that's behind all of this. Of course, it's not well shown here, called the ligament of Marshall, which is not pictured anywhere here either. But that's okay.
Okay.
The ligament of Marshall, it's kind of a funny little spot, but it was a part of the body when you were being, in utero, and certain parts of the heart become more prominent and others less. This area, combined with the posterior wall and the left atrial appendage, are very, very electrically active. The electrophysiologists have the ability to go in and burn the pulmonary veins because they're circles and they can go inside them. But the big swath of area on the posterior wall of the heart, which is the left atrial wall, it's much more difficult because it's a big area. So surgically, what we do is we wait to get the patients after they've had one ablation, and the ablation oftentimes is the pulmonary veins. And if the patient comes back and they still have atrial fibrillation, we will go in and we will ablate the entire posterior wall, the ligament of Marshall. We will either put a clip or sew the left atrial appendage closed. That is the modern modified maze procedure that Jimmy Cox initially sort of described, but we use now radio frequency, or we use cryo, which is just a freezing and thawing remedy, and all that does is damage the tissue. Now,
and that was the whole goal in the beginning. That's why he was making the cuts, to create scar tissue and change your direction. Yeah,
exactly. Now, if we're going inside the heart for, let's say, mitral valve surgery, or if in very rare cases we're going in for the maze procedure inside, I personally have never done that. I hear people do it. I don't do it. You can do these burns on the inside and the outside. But what we've been doing in the last few years is, when the patients come to us, we've been doing what's called a combined hybrid procedure, where they'll try to ablate them at first. We'll go in through a small incision underneath the bottom of the sternum, go inside and burn the posterior wall through an incision that's about maybe an inch or two big. And then we'd go in with cameras into the left chest and put a clip on the left atrial appendage. Now, some of you have heard about are you staring at this heart still?
Yeah, I was. It's there.
Okay. Some of you have heard about the Watchman device. This Watchman device goes into the left atrial appendage, and it basically covers the inside, and then the outside eventually will heal over. The purpose of that is to do the same thing. The problem is that you still have to be on blood thinners throughout this whole period of time. And the advantage of this clip that you see here is we will use those in patients that have bleeds in their brain, who have gastrointestinal bleeds, people who have bleeding issues in other areas, nosebleeds and what have you, things where they have problems. And we'll be able to put this clip on without doing the ablation procedure. And then patients can come off anticoagulation. And we believe, although we don't have data to prove that we can decrease their risk of stroke. Why don't we have data to prove it? So it's a very simple answer, Karen. If you take 1,000 patients and you split them in two, and you say, okay, we're going to treat this 500 patients to the best of our ability. We believe very strongly that this works. It doesn't seem to hurt anybody. I myself have been involved in over 400 of these clips. And then we take the other 500 patients and we wait to see something bad happens to them. We don't do that anymore. No, that's not done anymore. So we can't get the data, but we are taking all the patients that we do this on and we are putting them in a registry. And over time, if the registry compared to the general population shows really, really dramatic improvements, decreased risk of stroke and what have you, then we'll have at least some data. Right now, we're kind of going with the reality that if there's no left atrial appendage, then a clot can't form in the left atrial appendage. And we're looking at the surgical data and saying that that data is good enough for us to justify.
There's a lot that goes on in the AFib world. What about other people that have other types of arrhythmia that we had mentioned before, the SVT, PBC, ABCs, all these initials? Do they get what is it that they're experiencing, and is there a way for them to receive any relief?
That's really a very good question. The problem always is, what is the cause of this? People who have had previous surgery, certainly in the initial postoperative period, there's a tremendous myocardial irritation that can lead to all kinds of arrhythmias that are usually extinguished by 6 weeks or 8 weeks. People who have prolonged arrhythmias, a lot of times those could be even related to medications that they were put on to help them with their arrhythmias, because we know that a lot of these medications that are antiarrhythmics are also pro-arrhythmic. And so you wind up needing a balance. And that's what the electrophysiologists are really good at, is understanding how these medications interact with a lot of other medications. And, you know, it's super complicated, especially when you get into scenarios where people are on thyroid medication, or people have renal failure or renal insufficiency where they're taking medicine to keep their potassium or magnesium or calcium in check. It's super complex.
Yeah. And I love when you had mentioned about even mentioning an EP. I had not really heard of them either until my cardiologist, who was like, okay, I think I've exhausted everything in my toolkit. Let's go together and we're going to talk to the EP. You have your meeting, I'll have my meeting afterwards. And I just thought, this is the way healthcare is supposed to be. This is lovely. I'm just the person and they're going to have their powwow. And when I met him, it was, you know, of course, he's like, oh, this is nothing. I have people that go through this 24 hours a day and they never lets up. At least you let up. And it's just annoying, but you'll be fine. So, you know, it is interesting. There's a lot of different medications. There's so many different things I need to now, in my own personal case, take into consideration. But I think that you're right with that 6-week mark too. I have found after having bowel resection for at least 6 weeks, I was experiencing a lot more palpitations. And I realized if I could get a lot of that gas that was in my body from surgery and get those intestines really moving, once all that subsided, then it all went away. And is it because the gas or something hits a nerve in there that then just triggers everything to go wonky?
I don't think anybody really knows. We still don't even know why, when you do heart surgery in a patient who has no history of atrial fibrillation, why 30% of those patients go into AFib just from the irritation of mucking around with the heart. No one knows, but we know it happens. And we've tried to preemptively give patients all of these medications, and they've universally had no results except for complications. And so we stopped doing that altogether.
Yeah, that's crazy. It's still so interesting to me, just listening to the technology and the changes in the thing, and just understanding the electrical nature of a heart. I find fascinating. I'm too old to go back to school, but I learned through you, which is nice. I'm going to check in with Josh and see who's with us now, and if there's any questions about this topic, and we'll open it up to questions about anything, because why not?
Hello. We have some questions. First off, Tim says, can we get a Bridgewalk shirt preview?
Oh, yeah. Maybe. Let's see what we can do. So Aortic Bridge, which is our organization here in New York City, has a walk every year. And I think I do have a picture. I had a picture.
Drum roll.
Yeah,
These are great shirts too. I'm adding to my bunch.
Your collection.
Yeah.
Gonna have to slow your roll. I'll work on that. Any questions related to the other stuff?
Yeah, we don't have all of Dr. Youdelman's time. What else do we have?
That's fine. I just want to
get to it while you're looking.
Brenny says, "Will there be gluten-free options for the bridge walk?" Brenny,
yes,
he's got weak genes.
Yes,
of course.
Mark here says, after following medical advice and consistently walking and doing resistance training, my PVC and runs of AFib have all but gone away, also keeping my BP down.
Well, look at that.
I think that's just good luck. I couldn't tell you that necessarily happened because or from or anything. Nobody's going to know the answer to that one.
Yeah.
But I think it's beautiful to hear. I love to hear that.
Yeah, I was just going to say, it's encouraging because every time I finally start some type of exercise, mine kick up. It just makes it worse. But I don't know again if it's because of that or if it's something else. So it's just telling me that it's
classically
not
that's not should, but that's what often happens is people will have an increase in physical activity and then wind up with more symptomatology.
Yeah.
Your drum roll is ready. Okay, go.
Okay. Oh.
Yeah, it's a terrible drum roll, but anyway, here they are.
Oh, we got black shirts. Is that what it is this year?
Are we focused? Why are you not focused?
It's not catching it.
It's not
Put it in front of you. Like, do it like this, right in front. Yeah, no, it's not doing it. You can email it to me and I'll share my screen real quick.
If you want. Absolutely, yeah.
That's a great logo. I love that it's got the Coney Island, the parachute jump in there. It's a great logo. And the bridge, genius. I don't know who created that.
Came up with that.
Okay. Okay. Elena says, my cardiologist took me off of my Eliquis, and then I had a Holter monitor for 7 days just to be on the safe side that I might wasn't having any AFib, and I've had it 3 times since dissection. I've never had AFib before, and I've only had it 3 times.
Yeah,
I'm right there with you.
Yeah, I mean, that's going back to the fact that people will get it. And we don't really know. We don't know. It just happens.
Initially, mine was caught on my watch, on my Galaxy watch, but it always says that. And then I'm always sending it to the cardiologist, and she's like, "Nope, that's an SVT." It doesn't know. It's either inconclusive, normal sinus, or it says AFib. But 9 times out of 10, when it says AFib, it's never AFib. It's something else. But it's been caught a couple times, and now I'm on Eliquis, and they're keeping me on until my valve gets replaced. I don't know when that's happening. Look at that beautiful design. What's the tower called now that took over from the trade centers?
The Freedom Tower.
Freedom Tower, that's right. So you got that in there. You've got all these iconic buildings. It's fabulous. Empire State. What else is in there?
Empire State Building, and this is the famous jump, the parachute jump.
The Comet.
The Cyclone.
Cyclone. Sorry, right.
This is sort of a pseudo replica of the bank building in downtown Brooklyn. These are kind of, this one actually is, I don't know who owns this building now. It used to be a Citibank building. I don't know who owns this, and I'm not sure if this is a washboard or what this was, but it looks very cool. I've never really known. Somebody was looking at the skyline and they decided, but I love the and then we got it on the sleeve. Then on the sleeve is going to be 2024 and Pink Aorta on the sleeve. Yeah,
love it. Oh, and I'm so happy it's black.
Yeah, it was good. Listen, it's
That's a good choice.
It's time.
That's a good choice this year. All right, Josh, what else we have?
Let's see. Mark responded with, it was the only thing that worked. I tried cardavetilol and atenolol. So it looks like just the resistance training and everything did its job.
No, I mean, that's beautiful. I have to say that, the thing about it is that if you're symptomatic, it's brutal because people, of course, get so worked up when they have these arrhythmias. And if you've had a dissection, I mean, any weird pains in your chest, you think your head's going to blow off, and it's just not fair. it's very, very difficult to sort of quiet the reaction in your body when you're talking about pains in your chest after you've had a dissection, which resulted in, a near-death experience. I mean, it's totally unfair. I mean, it's a really unfair reaction. I do think, like all of these things, I think expectation management, as my wife has told me, is probably the key to life. Certainly the key to marriage. At least my first wife has told me that.
You're first and last.
As I call her. Yeah, she said she'll never leave me and she'll probably kill me. So that's how that goes.
There you go.
That's the kind of woman you want to keep around.
Well,
Tim wants a gluten-free shirt.
Oh yeah, the gluten-free shirt. Yeah, that actually, you can eat that shirt. It's not a problem at all. It's very safe to eat the shirt for celiac disease. No problem.
Let me ask you.
Yeah.
If you're having an issue with your valve, can that cause an issue with any arrhythmia?
That's a great question, Karen. And I always turn to you for most of my medical advice. The mitral valve, when it is leaking, will cause blood to back up in the left atrium. The left atrium is this chamber that we just discussed, is communicating from one corner of the chamber to another corner of the chamber. And if those areas are stretched farther and farther and farther apart, then what can happen is that another area can say, oh yeah, you're having a long distance relationship. Well, I'm right here, so I'm just going to talk to her, and that's that. Boom. And next thing you know, you're in AFib because these two areas are competing for the electrical signals, and the electrical signals are no longer coordinated. That is what happens when mitral valve regurgitation becomes symptomatic. Patients either become short of breath or they go into atrial fibrillation, or both. Both of those are indications for mitral valve surgery when the patient has either mitral valve regurgitation or mitral valve stenosis, which is when there's a narrowing.
But not with aortic valve.
Well, the thing about aortic valve disease is that if the aortic valve is leaking, or if the aortic valve is stenotic, but the mitral valve is not diseased, then the mitral valve may over time start to leak, but it's really the mitral valve problem that leads to the dilation of the left atrium. Now, you can honestly say, well, it was the hypertension which caused the aortic valve, which causes the left ventricle, which causes the mitral valve, which causes the left atrium, which causes the AFib. Yeah, I know, Karen. I went to medical school. They're all connected. But you know what I'm saying? But the fundamental valve problem that causes it is the mitral valve leaking back up. But you're absolutely right. All of these things can cause it. But when patients present with new onset atrial fibrillation from mitral valve disease that was undiagnosed, it's usually because the left atrium has gotten so big that the coordination is less possible because of the distance between the two electrical systems. Once that starts and we go in there and we start doing our thing, we actually try to reduce the size a little bit. We do the ablation procedure from the inside, and we replace or repair the valve. It's pretty complex, but the idea is that all of these things, of course, are interrelated. They're a bunch of intertwined concentric circles.
Okay. Next question or comment. What you got, Josh?
Okay, I have a question. What would be the feeling that one gets if they are having AFib?
So, what people talk about classically, these things called palpitations are actually, as I said, they're not really related to the heart. They're just any feelings that you have in the chest. But if you just isolate the patients who are in atrial fibrillation, they will describe a couple of really interesting things. They will describe that they feel a fluttering in their heart, and then they'll feel like a big contraction, and there'll be like a rush, feel like big air, not air, but big rush of blood up into their head. And that actually is a very, very well documented effect. And what happens actually is that if your heart is relatively normal and your heart squeezes on a regular basis, well, then your body gets used to this generation. But what if it's like doing this? And then it stops for a second and it expands out. Now it's bigger. It has more blood in it, and it's strong, and it just goes oof.
Yeah.
And you feel that rush of blood, and you're like, people feel weird, and you get these very strange sensations. Many people will say they feel this rush of blood like around their ears, or they'll feel it in their eyes or in their head. And that's because, of course, the blood vessels to your brain are the first set, after your right arm, after the coronary arteries. And there's a lot of blood pressure changes that can occur. And so you feel it. So that's one of the weird sensations that people will get. What I always tell people is when you have these funny sensations that you think are palpitations, you take your hand, and for many people, not everybody, if you look at your hand and you go down the thumb, there's this tendon right here. And if you go next to the tendon, there should be an artery there. Now, my wife and a number of people, instead of going this way, it actually goes over the top, and it's here. And if you have one there, don't worry about it. It's not a big deal, but it comes over the top as opposed to being on the, on this side. And if you're feeling palpitations, just put your fingers on the pulse and feel the pulse and feel the palpitations. And if they're the same, well, then you can go to your physician or however you're going to bring it to somebody's attention. And you say, listen, I put my finger on my pulse, and those feelings that I had in my chest and my head, they were in sync with my pulse. But then other times, if you are doing that and you have these funny feelings and you go and listen to your pulse and it's just like bum, 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 you start focusing in on your pulse and you realize they're not the same. They're totally different. Focus on the pulse, not on the weird feelings, and you'll realize that it's something else. And once you know in your mind that it's something else, you'll probably calm down a bit. I can't say you definitely will. Present company excluded, of course.
I've never heard that, but that's almost like a grounding technique, and I kind of like it. And I'm going to do that.
It is a grounding technique, and it's a very well-known technique for people who have panic attacks, because some people will have panic attacks where they do not get a rapid heartbeat, and other people will have panic attacks because they just went into SVT. If you're in SVT, you should have a panic attack. You should seek medical care because you need somebody to slow your heart rate down. But if you're having that feeling of a panic attack and your heart rate is normal, but you're emotionally panicking, and you put your fingers on your pulse, you're like, oh, this is kind of weird. I don't feel great, but I know that it's not my heart. That feeling of shortness of breath and that feeling of heart attack and that feeling of horribleness will improve. So you should always use that technique whenever possible, and definitely if you have palpitations. But going back to the question, you're going to feel all kinds of weird stuff. And your job as a human is to say, is this related to my heart or is it unrelated to my heart? Because as I've told many people and many patients, whatever's going on with you can only be interpreted by your physician if you give them enough information to make a reasonable diagnosis. So you keep a pad of paper or you write it on your phone and you write down your symptoms, you write down what it felt like, you write down where you were, what you ate, blah, 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 blah. Like with Karen, I've had my 57th espresso and it's only 10 o'clock in the morning. Well, maybe you should have only had 42, Karen.
Not I. Now, is that same thing work for when you can see your heart pounding here? Because I've captured the arrhythmia. I'll zoom in with my phone and send it to my doctor and be like, look at that. What is that? Because ever since it was resuspended since surgery, I just stare at it and I just watch it. Boom. And I can focus on that.
Reason number 453 that Karen Anderson is not my patient. Reason number 453 that Karen Anderson is my patient. Video chats with her neck.
But it's true. But can you do the same? Like if I feel it here or I see it here, is that the same as my?
How are you? It's so nice to see you. What's going on?
You push my professionalism. Jesus. All right. But is it true? Just answer the question. Is it the same as feeling here? Okay. I hope you're all entertained and laughing right along with us.
I think the answer is yes, it's the same. If you want to take your pulse at the base of your neck, you certainly can, Karen. It's true. And your pulse is often here. The trachea is in the midline, and you can go just to the side of the trachea, and you can take your pulse there if you really want. I don't recommend you taking your pulse there, because when you're excited and you start pushing on your carotid artery, you also don't feel very good, and it can make you feel kind of crappy.
Well, I'm just talking about this.
Your chain?
Did you see it moving? Yeah. I videotaped that. Look, everybody does what they have to do.
Reason number 49. Persistent visualization of the base of Karen's neck.
All right. Josh, do we have any other comments or questions?
We have some comments.
Exactly.
So Mark says, my PVCs were not mild when I was really deconditioned. There would be like a bang in my chest. Sometimes with each inhalation, it's like it was not getting enough oxygen fast enough when inhaling. And I could feel them in my left carotid, kind of like what Dr. Ben described.
Yeah. It's the boom. I like it when there's that pause and then it's a really big boom. I'm like, oh, thank God it turned back on.
Yeah, I mean, there's a bunch of signs and symptoms that we have. There's something called a Brockenbrough beat, and this was Dr. Brockenbrough. And the whole thing is that the Brockenbrough beat is when you have a pause for any reason. Again, your ventricle will fill, and if your ventricle is otherwise strong and normal, you now have a pump that's filled more than it normally is, and when it then squeezes, bang, it's just like, it's pretty dramatic. And depending on where you're at, what you're feeling, and what's going on, it can feel pretty strange. I mean, everybody gets them. I get them. Everybody gets them. It's a normal thing to have arrhythmias and palpitations. That is completely normal. It's a matter of when you get into a situation, when you have a condition that has been life-threatening, all of these things raised to a different level. Like, I understand. But our job in the medical community is to try to bring things down and explain to you, okay, these three things, this is special to you. It's a big deal. You have to worry about it. It's not normal. It's just what you've got. And this is the hand you've been dealt. We're going to keep it out. But these other 30 things, everybody has those.
Right.
And try to define for yourself the line where this is abnormal and this is normal. And you can't do it right off the bat. I will tell you, and all of you know, that in the first 3, 6, 9, 12, 24, whatever months after, especially type A repairs or type B dissections or any sort of emergency surgery, you're going to be calling and coming back to the hospital, and you're going to be, and that is why aortic hope plays a vital role in the care of patients. It's not some sort of junkorama situation. This is not a fly-by-night thing. This is the actual care of humans. Because if you get right down to it, once I've put your aorta back together and we've adjusted your medications, what's the rest of it? The rest of it is you becoming comfortable with what I'm telling you, to the point where you're like, okay, every time this happens, I don't need to run to get a CAT scan. Every time this happens, I don't need to run to the hospital. Every time this happens, blah, 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 blah. And it's hard, and we know it's hard, but that's the real care of humans. And I do think that the group, Aortic Hope, creates an environment where you can care for each other in a much more valuable way, honestly, than I can care for you. I can tell you anything you want under the sun, but until somebody who's got what you got tells you it's okay, oddly enough, you still don't think it's okay.
Well, it's been almost 10 years for me. And even when I was telling Josh earlier, I was woken up in the middle of the night last night, in the middle of sleep, feeling some type of arrhythmia so bad that I sat straight up in bed and I was like, I'm about to pass out now, nauseous, dizzy, cold sweats, the whole 9 yards. And I put my hand here. That's comforting to me. And I just took some deep breaths and I was just like, all right, let me do a quick body scan. I feel no pain. I think I'm good. I'm going to be fine. I'm going to be fine. Because your first thought instinctually is, this is bad. I think I need to call 911. I'm really twice in my life woken up to feeling like I'm about to pass out. And it's very jarring. And I got it together. And I didn't call 911. I just, took the breaths I know I needed. I resituated how I was sleeping. I slept sitting upright because I thought, well, do I have reflux? Like, what's happening that's causing this? Because I'm not uncomfortable. I know I don't have high blood pressure. My heart rate was elevated. Could have been a shot of adrenaline from anything. So I just tried to self-soothe. Didn't go to sleep till 6, but then I got 3.5 hours of good, solid sleep without any interruptions. But it really set the stage for a day today because it plays with your mind. But you just have to keep remembering they are annoying. They are not life-threatening. I've survived the life-threatening. I know the difference. If it's something different, I then bring it to someone's attention. But this is just the worst case scenario of the same things I've been feeling. And now there'll be tomorrow. And if it's different, you definitely need to say something and take a deep breath. Don't I get like number 525 reasons on why you want me to be your patient when he's done his call? That's what he'll say. He's going to do it.
He's calling your doctor right now. Elena is asking, is that AFib when it goes boom?
No, that's when the ventricle or the area of heart he was discussing had a pause for whatever reason and filled it with a lot of blood. So now it's going to squeeze really hard, and that's the boom. So you can get those with other types of arrhythmia. It's not the AFib is the heart that's just fluttering. It's a flutter, just not in a regular rhythm, like that. That's the AFib.
Mark is wondering if perhaps you had some sleep apnea.
I've been tested twice. I do not have any, but I did put a call in first thing this morning. Medications have been adjusted to try to combat this. The thought is,
I'll be back in a minute. I just have to take a call.
No, go ahead. The thought is that I have broken through one of the meds. My body's just gotten used to it, and we're just going to play with some meds for a little bit, which, when you have a valve that's not doing great, that's why I asked the question. My valve is at 40% regurgitation, and I have 2 aneurysms. When you have that, you have to think, is this contributing, and why can't I just have surgery? And the answer is because it's not time yet. And the reality is I want to wait. Because if I can wait a couple more years, maybe I won't have to have open heart surgery. Maybe they'll come up with a technique and I won't need it. So, definitely not sleep apnea, even though I've been told that I do kind of purr. I don't snore, a little bit of purring that goes on. So,
you mean you grind your teeth? Is that what you're saying?
I wear my retainers from my Invisalign, and God, as soon as they go in, it's like, I know it's time to go to sleep. I love those. I do not grind anymore since I had that.
So you do grind your teeth?
I used to. And then I did Invisalign, and then I got out of the habit of grinding. But I just like wearing I will wear my retainers. So, but I wake up, my mouth is like tight shut. Not tight. It's just, I love my retainers. So I'm all about them. Yeah. Am I making you laugh? Should you come up with that reason 620 on why you want me your patient? Because I'm entertaining.
No.
Keep you on your toes.
Yes, indeed. I'm sorry. I'm waiting to be conferenced in with an insurance company. This is
that's all right.
My life is so silly.
We're at a little after 4. Does anybody have any other questions? Because we probably need to let you go and deal with all this stuff.
Elena says, sometimes I wonder if it's what we're dreaming about that kicks things off.
Yeah.
Right?
I think it can. Sure. You can have a dream and then just boom, have a sudden rush of adrenaline, and that can kick it off. And now you're like, well, what is going on? Yeah, I believe that.
Definitely. I think we have to be very reasonable to know that we don't know everything, and stop thinking that we absolutely have total control of the situation. There's some other stuff definitely going on. And I think though the most important point is to always say that, go back to your physician, make sure your thyroid panels are good, make sure your electrolytes are good, make sure the other stuff, your hypertension is under control. All these things that are extremely important for the maintenance of your body are going to affect all these other things. And especially as women get a little older and you go through menopause, there's all kinds of weird changes that happen with your electrolytes and temperature and thermal control and on and on. I mean, it's a super complicated time. And so it's important to just realize that, and also there's a certain subset of the population that's going to go into AFib irrespective of any of these things. So it may not even be related to this. And if you had it run in the family without the aortic disease, just consider yourself super lucky. You have both aortic disease and atrial fibrillation.
Right. I love it's the gift that keeps on giving in families.
Let's see if we can squeeze one last thing in.
Sure.
Harry is asking, control meds have high risks such as amiodarone?
Amiodarone.
Yeah. Any other options?
I'm not sure what you mean by high risk, Harry. I would say that amiodarone has been our go-to, one of the safer drugs that we use. There's no question that none of these drugs are perfect. Amiodarone does have a risk of lung disease and a risk of thyroid disease. And in some patients, it has been shown to cause lots of problems. And certainly if you have a family history or if you yourself have a history of any reaction to these drugs, that's very bad. But in terms of a lot of these drugs, which, as we said, are both antiarrhythmic and proarrhythmic, there's all kinds of challenges. But as we showed you, atrial fibrillation itself is also a risk.
Right. It's a lot. There's a lot in the whole cost benefit. I was told by my doctor, she didn't tell me the name of the drugs, but that there was a drug that had the potential for a lot of side effects. And there was another drug that would have to be administered in the hospital over a 3 to 5 day time period to watch for depressed Q waves. I don't understand what this means. She just said, you don't want that, and we can monitor you and make adjustments as necessary. And I just said, after a very long pause, how about let's not do any of those? And let's talk to the electrophysiologist and let's try to reevaluate everything I'm taking, the times a day I'm taking it, and see if there's room to play in what's already going on. I cannot stand to take another medication to fix something else that a medication is causing that's supposed to fix something else. Like, I'm done. Let's get to the root of the problem, or let's decide what isn't the problem. I'd rather at least let's make some headway here. This is not an issue. I'm happy with that. That's progress to me. But I think it comes a time when it's like, let's not keep feeding this more medication to fix the side effect from another medication or another one. Let's just do a reset. And she agreed. And we're going to talk to the EP and evaluate everything and make a decision on what we need to do. And just, at some point in time, you're on a lot of meds and you don't know what's causing it, what's breaking through, what the issue is. And so that's what working with a strong team really enables you to figure out. All right. Ben is on an important call.
Right. I feel like Tim called him just to give him a little bit of
probably,
just to like, I will not prank call my doctor.
He probably did. All right. Well, we are probably going to need to say goodbye to him. Thank you guys so much for joining us and tuning in. Really appreciate it. Please don't forget to click like and click subscribe and click the button, because our next upcoming live event is actually on the 10th when we interview let me make sure I'm right. Yep. When we interview Gareth Owens from Aortic Dissection Awareness UK and Ireland, ADA UKI, and he is also the chairman of Think Aorta Global, and he's going to talk to us a lot about what is going on overseas.
Hey!
What do you want to talk about now? Well, I'm just talking about, I'm interviewing Gareth next week. We're going to talk a lot about what's happening with the World Health Organization.
My gosh. Are we still in
going
the
on
group
in Think
setting?
Aorta?
Is this still the group? I have to say that Gareth has just been his sort of status in my eyes has just been launching enormously.
Yeah.
Gareth Owens is just had the ability that I think to some degree is related to the accent, because the English accent they seem to be able to say anything, and everybody just
sounds you're so smart. But he is so smart.
So nice and smart, blah blah blah. But I mean, his ability to navigate some of the complexities of this world where really everybody is just trying to do the right thing and to help out. But I do think that there's been challenges along the way, and his steadfast ability to captain this ship through this stuff. We are now in 14 countries or 15 countries soon. Maybe it'll actually wind up being more than that if we wind up getting the support of basically the entire European Union, which we're going to find out shortly. And really our ability to stay on point and say a very simple message to the world about what we need to do to save more lives by far carries more weight and is better than any of the other things that have ever been said before. And it's just amazing that he is able to just stay on message, and we're all there to support him along the way. And so it's going to be a lot of fun to be in Europe with you, Karen, and really explaining to.
Are you wearing a kilt? Is that where you wear kilts?
I don't know if that's any of your business, Karen. My desire, ability, or tailored, condition.
The weather should be nice.
To wear a dress is really not something I need to talk to you about. I'm bringing my daughter, and that's really all that matters.
It's true, but you're right. The simplicity of Think Aorta, 2 simple words that is doing so much, changing so much. It's affecting so many. It's incredible. It's really, it's amazing. It's very humbling to be able to be a part of that. I get really overwhelmed from both sides of the coin that I get to be a part of and a piece of. So that's really exciting.
Yeah, but it's not just that, Karen. It's the 1-2 punch. It's the fact that Think Aorta has been able to invade people's brains, and then everybody's sitting there going, well, now what? And then Aortic Hope can come in and say, we're the now what? Now that you're here, now that you're there, now that you found us, now that you've learned the pathway, now that you've had the disease or heard of the disease, we're here to support you along the way. And I have to say that your ability to maintain your organization and realize in your, see if I can remember this,
reactive,
which is Think Aorta,
proactive,
which is
it's the combined,
and Think Aorta, and reactive, which is Aortic Hope and all the rest of us, to react to people who've had the problem, in a way where it's so clear where everybody needs to be in their lane, and have these incredible effects on not just the patients. I think that's where the whole thing carries so much weight, is being part of this is affecting the entire healthcare network and the hospitals and everybody who works in part of this. And I mean, it's just miraculous that we're getting more and more people to fall in line and say, you know what, let's just join the train and march forward, and let's keep this going. And it's just fantastic. I really agree with you. It's so awesome just to be part of it. So you're interviewing Gareth when, next week?
Yeah, on Tuesday. But the whole entire thing is just helped both sides, patients and physicians, do what? Ace their healthcare journey. And we're going to talk about that. I think you and I need to go on again and do a live, if we can fit it in before the end of the month, and present how we can show people on both sides how to ace that healthcare journey. We should do that together.
Do you want to do that in advance, or do you want to do that as a summation? Should we do that when we get back? I sort of feel like it's like the when we get back thing.
Sure, let's do it when we get back. If you want to do it like on the 24th is when I was going to show it as a post. You want to make our presentation be that post? Let's do it at like.
Wow, that would be so fun. Except I'm going to be having.
You're going to still be gone. Yeah. How about the 25th?
25th, I arrive in Newark Airport at 4:00 in the afternoon.
That's not going to work. Okay. All right. So you let me know how Thursday or Friday is working for you, and I'll make that work for me.
We'll make it happen. We will make it happen. I do think us presenting this concept of what we're presenting there is just a beautiful thing.
I think it is.
All right, listen.
I know. Thank you so much, as
My
always. And
pleasure.
I love the new information. I appreciate it. And to everyone else, don't forget to click like, click subscribe, click the little bell, and we will see you soon. Enjoy the rest of your week.
Thanks.
You're welcome. Bye.
Bye.